So Kelly, I think you want to start driving. We have a PowerPoint presentation. And before we start,
absolutely.
Thank you. Before we start, I did put some reminders in the chat that this is really a meeting for the ROC members, and but it's not a public hearing. So there's no opportunity for public comment or interaction with the council. And we're asking for those of you who are stakeholders and the public, if you could turn off your microphone and cameras, which I think you've already done. So thank you for that. We do have the chat accessible. However, just note if you make any comments or questions in the chat, that will not be part of the public record, and we will not be followed up by staff. For the council members, if you have a question or comment that you'd like to put in the chat, you're certainly welcome to do that. So thank you very much.
Thanks, Robin. And thank you, Claire, and to the rest of the Opioid Region Council for having us out today to talk a little bit about what's been going on in our community, both with opioids and the general epidemic and the impact that it's had, but also what staff and community partners have been doing to really pull together and plan for settlement dollars that are about to land within our region. So as Robin mentioned, my name is Kelly Veit. I work with Boulder County Community Services on the team that has been pulling some of these efforts together with community partners. And I'm going to go ahead and kick off our staff presentation to you. This is a really brief meeting reminder. Again, the meeting norms that Robin just mentioned, we are asking that any questions or comments are put into the chat until the breaks in the presentation. We're going through a lot of information, and so we did design sort of segments of content that will allow for questions or comments as we move throughout. And of course, if those questions, burning questions come up, like Robin said, go ahead and feel free to put those in the chat. So we do want to start today with a personal story of impact from opioids and the epidemic that has sort of ravaged our communities. We know that we're about to spend the next hour and a half talking facts and figures and recommendations. And we don't want to lose sight of the fact that we're also talking about lives that have been impacted. We're talking about our community and our members of our community. And so I want to introduce Mila Long, who is here to spend a few minutes sharing with us her personal story of how opioids have impacted her life and her road to recovery. And so Mila, I really, really appreciate you being here to sort of ground us in the right perspective. And I welcome you to turn on your camera and share your story.
Can you guys see me? My camera's on. I can't see myself though.
Ellie, do you want to take the presentation down so we can see Mila better? Thank you.
Sure. Okay, am I on the screen?
Yeah.
Okay, I'll begin by saying I'm just a little bit nervous, guys, but my name is Mila Long. I am a person with lived experience from opioid use disorder, or in other words, I am a survivor of opioid use disorder. I'll also begin by saying that I'm a certified addiction specialist and counselor, and I have been working at an opioid treatment program for the last 5.5 years. So I've really seen how this epidemic has affected my clients firsthand, as well as obviously it affected me for many years. My substance use began pretty early on, just with experimentation, smoking marijuana. In high school, I was an athlete. I was one of the top swimmers in the state, varsity. And just like any athlete, I had injuries, but I started experiencing a lot of chronic pain in high school. I was in and out of the hospital. I was having many tests done. And eventually it got to a point where they decided to prescribe me opioids. They had no answers as to what was going on with me. It was pretty scary for me and my family. And to me, this seemed like a godsend. I took that first pill, and the only way I can really describe it is it felt like home, right? I pretty quickly started self-medicating with that. I was also drinking a lot. and using that to not only escape physical pain, but anxiety, lack of confidence, a lot of things that teens go through. I was never taught about opioid use disorder in high school. I think that there was one PowerPoint presentation in a health class that I think I slept through half that class, and most of the students there did. And I feel fortunate to be a part of a program called Youth in Recovery today, where we go into the high schools in Boulder Valley and we're able to share personal stories and I think reach them a little better. But I had no idea that this could take my life over in the way that it did. So by the end of high school, I had switched to heroin because I was running out of my prescriptions early. I was taking more and more of this opioid medication, oxycodone. I couldn't refill the prescriptions early. I was raiding my friends' medicine cabinets, and I wanted to feel this feeling every day, right? But I was also in denial that it was a problem or that I didn't have control over it. Until I went on a trip, right? I went on a trip with my family after my senior year, and within 24 hours, I was in full-blown withdrawal. If you haven't been through opioid withdrawal, there's no way really to describe it. It is, people say like the flu times 10, but it's far worse. And at that point, I promised myself I never want to go through this again. And unfortunately, I did many, many times throughout my my struggles with opioid use disorder. But as soon as I got back, my use just ramped up, and it was kind of off to the races. Over the next several years, I was injecting heroin and cocaine. I burned pretty much every bridge. I was in a lot of unhealthy relationships, committing crimes in order to support my habit. The only real support I feel that I had was connection with the Works program in Boulder County, where I could go to get safe injection supplies. There was peer support there. I could be connected to services. I could have, HIV, Hep C testing, and I felt welcome there. I just want to touch on how impactful peer support was for me. Even though I went for years using opioids, having a peer throughout that time, even if it was just when I went to pick up clean needles, was very impactful, right? And when I finally did get sober, it was one of the most meaningful things for me, which is why I decided to enter this field as well. I went through many treatment programs. I went to residential programs. I went through intensive outpatient. I went to detoxes. And every time I either left early or I was kicked out because I continued to use. I didn't understand that there wasn't something morally wrong with me, right? And one of the things that we teach one of the things I teach in the groups that I do with my clients today is how substance use affects the brain. That it completely takes over, especially opioids, right? They take over our endorphins, which is something we need in order to function and feel normal. And there's a quote that says, addiction lives in the part of the brain that tells us to breathe. And I resonate with that very strongly, right? This was a survival instinct for me. I felt that there was no choice. And of course there was, but it certainly didn't feel that way. And no treatment programs were working. And everything that I had heard about medication-assisted treatment on the streets was not good, right? And I had never been referred to that. It wasn't until I hit my very rock bottom after my last overdose. It was about my 6th overdose. I was left by 3 people who I thought were friends of mine. And I was fortunate to be revived. And in the emergency department, they told me that if I didn't stop, I was going to lose my left arm due to the infections and a lot that was going on with that. The first thing I did when I left was use, right? That it was the control that it had over me and how much it consumed my life. But I started methadone a couple days later. I had no idea that this was such a life-saving medication, that I was 4 times less likely to overdose by taking this medication, even if I continued to use, that it was the most successful treatment for opioid use disorder. And it saved my life. Naloxone also saved my life. If it wasn't for naloxone, I wouldn't be here today, Narcan. And I just think that's a very important message, right? That everything we are doing in this field is to save lives, and overdose is preventable. I lost my best friend to overdose in 2019. And to this day, I have lost, I believe it's 24 people to overdose. So every single one of you being here means the world to me, that we have these funds, that we're able to hopefully help the community even more. And I hope that my story just, in some way can be inspiring to you guys, that, this is no joke. I thought that I would never make it out of this alive, right? And sure, I've had relapses because it's the hardest thing I've ever had to do. But I thank you all for hearing me out, and yeah, I think that's it.
Thank you, Mila. Thank you so much for being here and sharing that with us. I'm really quickly just throwing the slides back up. And I know we do want to, before we jump into any more staff presentation, we do have one administrative item to be handled by the Region Council. So I'm going to pass back to Robin to go ahead and talk us through this one.
Thank you, Kelly, and thank you so much, Mila. Really appreciate you being here. So when we were forming the council, we had many conversations that were fairly informal. And I believe the vehicle we used was the county administrator meetings that was set up weekly for the Marshall Fire and COVID. So in those conversations, we talked about the need for a chair, and our IGA asks us to formally appoint the chair. And I'd like to propose that Commissioner Levy serve in this role. And so that would require a vote of the council, or if there are other nominations of existing council members, which from my belief around the conversations we've had about this previously, having a commissioner chair the council made the most sense for people. So I'd like to nominate Commissioner Levy, and if I could have a second.
I'll second that, Robin.
Thank you, Joe. Any additional conversation or other nominations people would like to propose? Okay, seeing none, we could have a vote of the rock with thumbs up, either on screen or with the little icon. That would be great. Thank you so much.
And thank you all.
Yeah.
And we know who's really going to be running this, but thank you all. And I'll do my best to do a good job.
The other requirement in the IGA, which again was discussed when we talked with the city managers and town managers around convening the regional council, was who would be the fiscal agent. And at that time, no one other than the county raised their hand. And so given that the county itself is receiving dollars and you all have signed IGAs supporting your funds be pooled with county dollars, the proposal on the table is that the Boulder County would serve in this capacity. So if anyone else would like to raise their hand at this point for another suggestion, otherwise let's formally ratify this decision. So if everyone's in favor, again, thumbs up either on screen or with the little emojis. Looks like we have consensus. So thanks so much for helping us take care of these housekeeping issues. I really appreciate it. And I'll turn it back over to Kelly.
Thanks, Robin. So I'm going to start kicking off the staff presentation and just kind of get us started with a little bit of background, and then hand off to others who can talk through sort of the process by which we were able to come up with some initial recommendations to present to you all today. So by way of background, when we talk about opioid litigation, we're really talking about not just one lawsuit, we're talking about a series of ongoing lawsuits over the past few years and still ongoing that are really between regions and municipalities and opioid manufacturers and distributors. And really the intention of those lawsuits is to recoup damages or funds for damages and harm that has been done to the community due to the opioid epidemic. So the state of Colorado is broken down into 19 fund recipient regions, and Boulder County is its own region. Each of those 19 regions must have a designated regional council with elected officials in senior leadership. And really the primary charge of that group, or this group, is really to develop a 2-year plan for how to allocate the incoming settlement dollars across 5 approved purpose areas, which I'll talk about next. So in April 2021, the Attorney General released a report that outlined 5 approved purpose areas. And these are sort of the sectors that are approved for opioid settlement dollars to be allocated towards. So those 5 approved purpose areas are prevention and education, harm reduction, criminal justice, treatment, and recovery. And you can see underneath each of those sort of some examples of the types of programs that would fall within those categories. So it's important to note that all of our planning processes in the Opioid Operations Committee have been done across these 5 approved purpose areas. We're going to talk a little bit later about how these approved purpose areas have needed to sort of merge with the way these programs are represented in the Attorney General's online system, where we do have to submit our 2-year plan. But suffice to say, all of our planning at the operational level and the recommendations that you're about to hear were done across these 5 approved purpose areas. In terms of the 2 bodies that are sort of leading this effort, the Opioid Operations Board is largely advisory. This group has been meeting since May to develop policy recommendations and funding recommendations to the council here today. The membership of the Operations Board is comprised of nonprofits, government representatives, subject matter experts across the different program types in those 5 approved purpose areas, and of course, folks with life experience. And the primary charge of this group, again, was to develop the 2-year plan recommendations that we're going to go through later today. The Boulder County Region Council, this group seated here today, is overseeing the procedures by which the Boulder County region can submit that 2-year plan and then monitor the fund allocation process after submission. In terms of the breakdown of allocation amounts that have come to the region, so of the full allocation amount that went to Boulder County, 60% of that amount went to a regional share. So it went to the county itself. The remaining 40% of that Boulder County regional dollar was allocated across the remaining municipalities. The total settlement coming to Boulder County as a whole, Boulder County region, in year 1 is $2.2 million. And some change. And then year 2 is about $1 million. In subsequent years, we are anticipating will also be about $1 million. It is important to note that these settlements are ongoing, and so some of these dollar amounts are likely to change. Also important to note that prior to today's conversation, each of the municipalities had the option to take their local share and to pool it into the regional share. And I'm going to talk in a minute about what that means for our planning process. So the Opioid Operations Committee has been meeting since May to develop our recommendations. It has been throughout that process that some of these funding amounts have sort of shifted. And so the amount that we were working off of when we developed our initial recommendations is $1.8 million. Since then, any of the additional funds that local municipalities decided to pool into the regional share have been added to our full allocation amount. So that's why you see a discrepancy between the $2.2 million, which are the dollars that are under the full purview of this council, versus the $1.8 million that we developed our recommendations around. So I just wanted to point that out because moving forward, we are going to be having more conversation about, now that we have those additional $450,000 from pooling funds, what do we want to do with those additional dollars? We're going to make some recommendations about that in later conversation. So before we go into the next section, I want to pause and see if any initial questions, comments have come up from members of the Regional Council. All right, hearing none, I'll just keep on going. So we are switching gears a little bit. We're going to be talking about, what are the known impacts in our community from this epidemic. So we sort of broke down this next data section into two sort of components. And one is looking at the anecdotal evidence, or sort of that qualitative evidence from individuals that are on our operations committee and have that subject matter expertise. And then the second portion will be more of the quantitative figures of impact across Boulder County. So in terms of that anecdotal evidence, we had a conversation in our opioid operations committee a number of months ago, and we had this exercise called a landscape analysis, and we just asked the group to look across those 5 approved purpose areas and to let us know what's really going on in the community. So what are the strengths and the weaknesses that we know to exist across Boulder County in these 5 areas? And so these are some of the trends that came out of that discussion. In terms of prevention and education, the group identified that Boulder County has a strength in that Narcan and training around use of said resources, or said resources are more available. Boulder County also has really strongly established venues of collaboration. We have coalitions that are known to host educational campaigns, resource sharing, etc. Some of the weaknesses that we know about in prevention and education have to do with the fact that early intervention is lacking, and it's not necessarily coordinated with some of our harm reduction programming. We also heard a lot about not having enough targeted education or efforts to reach specific populations with that targeted education. Same for the clinical community, not enough outreach to the clinical community that has to do with safe prescribing practices. Also heard that we have a weakness in equity issues. All of the education and resources that are available are not available to specific communities. And again, having to do with, are we putting the right approaches in place to make sure that anything education-wise is actually reaching all of the specific communities that it needs to? In terms of harm reduction, we had an identified strength in that MAT and naloxone are more available and available in more settings. We also identified that there's an increase in programming that is sort of guiding an awareness and an understanding and decreasing stigma within different stakeholder groups that have traditionally not been maybe as involved in that front effort. There's also a long-standing historical support for syringe exchange programs. In terms of weaknesses, not enough safe injection sites, not enough safe syringe disposal sites, and remaining stigma around harm reduction philosophy, especially with specific populations. Also heard that naloxone still needs to be more available. Even as that accessibility is increasing, we need to have that available through more organizations so that the few with standing orders are not overwhelmed by demand. In terms of criminal justice, we identified some strengths in our partner coordination and a shared philosophy around decriminalization. We also identified a strength in our ability to initiate necessary care while incarcerated. So folks that are in the CJ system through various behavioral health programs in the CJ system are now able to get initial assessments, facilitate intake and treatment, case management, and then have community reentry planning. Also, new programming that is focused specifically on juvenile justice clients with co-occurring needs. In terms of weaknesses in the criminal justice space, workforce shortages and a lack of sustainable funding for some of those resources like treatment that are being offered while folks are in the CJ system. Another weakness, and not quite a weakness, this was actually identified as kind of a strength, but we need a little bit more of it. We have a lot of diversion programs, but the group did identify we need more. We need more to really prevent folks from even entering the system, so provided more at an upstream space, and then also to prevent re-entering the system. Another weakness identified is an inability to carry some of those services forward as folks reenter the community. So in that strengths column, the fact that we're able to initiate care is great, but individuals in those programs are finding it increasingly challenging to connect folks from the CJ system back to community-based resources. Another weakness that was identified is a lack of testing, treatment, and peer supports specifically for juveniles. In the treatment approved purpose area, MAT is becoming more available and in more settings. There is an increasing use of peer support specialists. There are more treatment and services being offered, also quicker access channels than previous for folks that are Medicaid funded. Navigation services for those with treatment needs, so helping connect folks to their necessary treatment and recovery supports. In terms of weaknesses, we identified that services aren't really equitable, so they're not reaching the correct populations at the correct time. We are lacking intensive outpatient and other treatment for specific populations, pregnant women, youth, LGBTQ+, uninsured, non-English speakers, and those with co-occurring disorders. Also, access remains difficult. So despite an increase in navigation services, we did identify that folks are just not able to access treatment at the level that is necessary. And then also identified is that the full sort of care continuum is broken around treatment. So it's difficult to really bridge these points of initial outreach, assessment, detox, coordinated entry, and then providing ongoing case management to folks as they reenter the community. And finally, our last approved purpose area is recovery. In terms of strength, the group identified that an increasing use in peer support specialists, again, also that there's a pretty low barrier to entry to some recovery-based programs, so a little bit more of the harm reduction approach. In terms of weaknesses, a lack of sober living options, not enough focus on recovery and transition planning. So as folks are moving from more intensive treatment spaces back into the community, that bridge is a little bit weaker than it should be. Not enough support and some remaining stigma around certain populations, and workforce issues yet again. So not enough staffing to really meet the demand. And also we heard a lot about there's no clear path to sort of a certification program for peer recovery coaches. So with that, I'm going to hand it over to Emily, who's going to talk a little bit more about those quantitative elements of impact on our community.
Hi, everyone. As Kelly said, my name is Emily Wolf. I am the evaluation manager for Community Services Department. I'm going to be talking about the quantitative side, and I just really want to start off by noting that even though I'll be discussing numbers, they all represent people. It's our community members who are affected by our opioid epidemic. I'm going to be discussing the number of people who have died or have had healthcare interactions throughout this presentation, and these numbers represent our families, our friends, loved ones, neighbors that have been affected. Also, as a heads up, I know that our slides are sent out ahead of time and mine have shifted a little bit. So just to note. I will be discussing kind of a high level element about this data. There is a opportunity for future more nuanced conversation. I'm going to be focusing today really on demographics and on types of opioids. The purpose of the section really, again, that lay of the land and kind of get a sense of the scope of the impact and harm that opioids have had in our community. I'm going to be discussing actual numbers more throughout because they're more easily understood. And again, I'll be discussing actual people as a result. It's different than you maybe have heard in the past or in other contexts. It's usually more described in terms of age-adjusted rates, which are a way of looking at numbers in accordance with the population and takes age change into account. So just a thing to note that some of these numbers might sound a little different because I'm going to be discussing it again, the numbers rather than a certain amount per 100,000 population. Main points that I'm going to be discussing today are emergency department visits, hospital admissions, and deaths. These can help inform which data points we look to shift over time. And we don't necessarily have all of the things, those different approved focus areas. We don't necessarily have the data for that at a community level, but these are things that hopefully these different strategies that we deploy will be leading to impact. Really important to note as we go into it, I'll be looking a lot at rates. And knowing that emergency department visits are happening higher than either than hospital admissions or deaths. So when looking at it from a racialized lens, we are seeing an increase in all other races. I kind of data-wise access categories end up being white, non-Hispanic, sometimes unknown, like the emergency department visits chart, and all other races are the main ways that we're able to look at this. And so noting that since 2017, we have seen increasing emergency department visits and deaths for people who are not white, non-Hispanic. So we are seeing larger shifts potentially happening in emergency department visits. There's these unknown categories of just, we don't know the race for some of the folks coming through our emergency departments. Gender disparity, we are seeing males overrepresented in terms of opioid impacts. And even though to some degree, emergency department visits and admissions are close to 50-50, we're seeing close to 70% of males of deaths being among males. So just things to know as we go forward. And that emergency department visits are still much higher than we're seeing of deaths, but thing to know. And then going into age, we are seeing these large differences in terms of emergency department visits and deaths when it comes to age. 87% of opioid overdose emergency department visits were among those younger than 45. When we were looking at deaths, only 54% were among those younger than 85 or 45. So we're seeing a lot more age diversity in terms of who's dying rather than who's going to emergency departments. We're also seeing 25 to 34 in both categories have the largest segment of the population. Going into kind of what's happening in terms of type of opioids that we're seeing in the community. Drug seizures in Colorado are increasing at higher rates than heroin. This is for Colorado, again, this is Colorado on the whole. Most of what I'm talking about has been Boulder County. We've seen, as you can see, right, huge shift in terms of fentanyl, less so in terms of heroin. This is then also related to what we're seeing in terms of who is dying and of what. More deaths are from opioid analgesics than of heroin, especially in recent years. So 2017 onwards, we're seeing that shift kind of increasing. And when we're looking within the analgesic deaths, which is the chart on the right side, the number that include mentions of fentanyl have increased to where in 2020 it's it's a little over 50% of deaths included mentions of fentanyl. Opioid analgesics are kind of my understanding of them, so forgive me if I'm wrong, but it's basically anything that is manufactured in like that could be a prescription, but sometimes includes street production of them as well. So fentanyl is an analgesic. So to summarize, we need to keep an eye to these shifting trends in terms of both gender and racial disparity. We are seeing them shift over time. And fentanyl is on the rise in terms of seizures and deaths.
And a quick summary of the landscape analysis that I gave earlier. In terms of strengths that we saw across the board, across the 5 approved purpose areas, we did have the group identify that collaboration and partnership is strong across Boulder County. In terms of weaknesses, across all 5 approved purpose areas, the group identified workforce shortages, lacking services and remaining stigma around certain populations engaging with certain services, and inequitable access channels for all populations seeking treatment recovery supports. So with that, I believe we have a pause next. Yeah.
And I will say I'm right now, just to clarify exactly what analgesics is, I'm going to bring up a quick, I'm Googling for a definition to point to rather than continuing to guess around it. So I know that that's something happening in the chat.
Yes, there was a question about what are opioid analgesics, and those are the painkillers like oxycodone that folks continue to get prescribed after, getting their molars out or other surgical procedures, if I'm understanding. Vicodin, Percocet, Dilantin.
Hey, Kelly, it's Susan. Thanks so much to you and the group for putting all this together and all the work. So maybe this is for follow-up later, but I'm curious, you had put the overall strengths, our collaboration and partnership, and it was mentioned around early intervention that there's a lack of coordination. And I think getting a little more detail on that at some point would be great, from the ops group on kind of what they're seeing as far as the gaps there.
Sure, absolutely. And I know that specifically the ops members called out both that lack and then the lack of coordination specifically with harm reduction programming. So lacking that kind of bridge, but happy to kind of take that back to the group as well, get more.
And then the other thing that would be helpful is just how the group is defining early intervention. I know that depending on the system we're talking about, the prevention, early intervention, intervention can mean different things to different systems. So I think giving examples of the types of services and programs, initiatives that fall into that definition for the ops groups of early intervention would be helpful too. Thanks.
So another comment in the chat around, that a gap in programming includes the challenge we have around data sharing. So I don't know if there's any information about that, or if that should go back to the operations group to do more of an analysis on what data is available to be shared in terms of programming, services, access to services, who's accessing services, and the outcomes.
Yeah, I'm happy to take that one back as well, get a little bit more information. I don't know if it was specifically discussed, but yeah, happy to dig into it with the ops board.
I think this is, as most of us on this call know, this is a challenge across many issues, whether it's this use or, homelessness, some of the key issues, behavioral health services, data sharing continues to come up as a barrier.
Robin, are you gonna move us on to the next phase, or are we gonna have a little more time for discussion or digesting? Oh, here we go. Okay.
Yeah, let's move it ahead.
Okay.
I am now not muted. Lisa Moreno, I'm the Behavioral Health Strategic Planner on the Behavioral Health Planning team. And so my job tonight is to introduce you to the advisory board and walk you through the work that the process that they engaged in to get the recommendations developed that we'll be presenting to you tonight. The Opioid Operations Advisory Group Board is made up of 15 people, which includes people with lived experience, county staff, law enforcement, representatives from law enforcement, both the DA's office and the sheriff's office, City of Boulder, City of Longmont, and key staff from nonprofit partners in the community that are service providers. We also had a representative from the town of Nederland for about half of the time. The group started in May, met twice a month, and to date has met 7 times in order to produce the recommendations that we'll be presenting. And I'm going to turn this over to Robin for a bit more administrative work.
Yeah, so again, this is our attempt to follow the rules of the IGA, which asks me to nominate the members who have been serving and for the ROC council members to approve those who are serving. But I want you to think about whether or not you think that this group is representative of our community and folks who are subject matter experts. And if not, is there a desire to explore adding participants? Or you may see a staff person that is serving and you think there may be a different person that should be serving. Or is there a community group that's missing? So like you'll see at the end of this meeting, we're asking you questions that maybe you don't feel comfortable answering right now. So one way to figure this out is to say, when you look at the names and the staff people that you know that are subject matter experts, do you want them to continue to serve? And you could vote on your approval. And then we could also have an opportunity to add people as you go back to your leadership group or your community members or stakeholders to see who should be added. So I'll stop there in case there's any questions or discussion, or if people are ready to vote and formally approve this group, because they are having an operations board is mentioned in our IGA. It's a very important role, and they do a lot of heavy lifting for the work at hand. So curious how people would like to proceed. Maria?
Yeah, I'll just say from my perspective, I'm comfortable with the staff person who's here. Think it's a good representative, and also would love to see if we can get someone from Netherlands and defer if in the future, if there are additional folks that we want to, or missing folks, that will be identified from the group, and then we can certainly take a vote. But I'm comfortable with where we are, with perhaps a nod towards seeing if we can get Netherlands better represented.
Thank you, Susan. And then I wanted to note Joe put his thoughts in the chat, so wanted to make sure people saw that.
Yeah, thanks. I'm in support of moving forward with this group as well. I think I may have missed this, but was there exploration of having school district representation? I just am thinking again about that, the early intervention piece. There's a lot of the people on this list are involved more in the deep end intervention system. So I'm just curious if there was conversation about that. But I would be in support of moving forward with the group as it is today, and then having discussion about additional members later.
Lisa or Kelly, any response related to the school district engagement?
Honestly, I can't remember.
Yeah, I was just racking my brain as well, and I cannot recall if
7 meetings. I'm wondering,
Well,
Marcy.
Well, we can circle back to that.
Yep.
And I see Harold, you have your hand raised.
Yeah, kind of echoing what Nuria said. I'm comfortable with this group as long as we're open to adding individuals based on need in the future. I'm specifically thinking sort of representatives from our lead core group, but I'm having to be really cognizant also of workload, and I would like to chat with them. But I'm good with this if we have the opportunity to add people in the future.
Any other comments? I'm hearing that we could make a motion to, oh, Claire, please.
Yeah, thanks. And sorry, I had to get off camera for a minute. I appreciate Joe's comment here about Melanie, and I guess she was invited and doesn't have time. But I think since since the criminal justice experience in particular, the, you know, people coming out of incarceration and that transition and that support just seems to be such an important part of this or phase. I wonder if Melanie's not available, whether there's somebody else or whether within community justice services, maybe that's where it needs to be, but someone who has experience with that transition period from supervision to being in the community.
So for today's meeting, how about if I propose a motion that we approve the existing group, recognizing the need to add additional members and allow that flexibility and rely on the ROC members to forward names of people, as well as for the operation board to reach out to other stakeholders like the school district to add in the future. How does that sound? Harold?
I'd second that motion. The other thing is just being on the housing authority side and seeing the impact of opioids in housing. I think it would be good to also try to look to our housing groups as well.
Yeah, that's a really good point. Thank you for that. Any other comments before we call the vote? So let's vote the motion on the table to accept the existing group, recognizing the opportunity to add other members as we see fit. Okay, motion passes. Thank you. Lisa, I'll turn it back to you.
Okay. So our group, the strategy that we decided to take to get the recommendations as quickly as we could was one that was very concrete and was focused on shovel-ready projects. And that's in contrast to some communities that actually held significant convenings in the beginning and then didn't end up with concrete proposals, but opened things up for RFPs. The reason that we chose to go this route was for two reasons. And the first one was that we had a very short timeline and a lot of stakeholders that we knew that were already working in the space, and we wanted to move as quickly as we could. We also had the opportunity to build on work that had previously been done by county staff in a cross-departmental way. They knew that this opioid funds were coming down the pike, and so began last year and looking at shovel-ready projects. So that kind of provided us a launching point from just how to think about it. We ended up reaching out far beyond county staff. As you can see, we had nonprofits and city representatives on the opioid operations board, but we also reached out through the substance abuse advisory group to nonprofits in the community to get their input in terms of projects. So the first thing we did was to define shovel ready, and the definition that we came up with was that any project had to first fit into the approved purposes given us by the AG's office, and that it had to serve those most vulnerable. The dollar request for the projects had to be known. It needed to be an existing project that was either that it about to expire because it was out of funds, or needed to expand but didn't have the funding to do so. It could also be a new project that was ready to launch that just required some additional funds to get them over the hump. There were a number of conversations and polls that we took at the beginning of the process. The first one was the landscape analysis that Kelly already presented to you. We then asked everybody three questions, two of which are represented in this slide. And the first one was what they thought would be the ideal allocation of these funds across the approved purposes. The majority of the respondents of the operations group said that the money would be best spent if it were invested in all five, some funding in all five of the approved purposes. The next question was, where was the biggest need? Basically the biggest gap in the community. And you can see that treatment was by far the largest gap. The fourth question that we asked, that you'll see in a slide coming up, was, given the current reality of the opioid crisis, how would you prioritize investments in the approved purposes, and we had them rank all 5 of the approved purposes. After our original brainstorm and outreach to the community, we ended up with 63 recommended projects. We knew immediately that we needed some way to narrow those down. So we developed a scoring criteria. The first criteria was the degree to which the program addressed a known service gap in the opioid service delivery. The second was the degree to which the program addresses known barriers to service access. The third was that the demonstrated proximity to opioid use disorder or substance use disorder that were impacted by or led to opioid use disorder. The third was the degree to which the effort reflects specific needs of identified communities that are harder to serve because of their geographic location, or places where they're not services locally accessible. And then the fifth was that the request was financially realistic. For just a second. So after the scoring, we ended up with 34 projects that were $1.4 million over the amount available. Additional recommendations that the group made was that they really wanted to invest all of the year 1 money. And this is, at the time, as Kelly mentioned earlier, we were working from a $1.8 million number. So they wanted all 1.8 million invested in year 1. They did not want to hold any of that money back for year 2. They provided a number of recommendations of how to use any unallocated dollars that you'll see those recommendations on one slide later in the presentation. And then when I told you the fourth question that wasn't on the slide, given the current reality of the opioid crisis, how would they prioritize investing in the approved purposes? They wanted us to use the answers, the ranked answers to that question, to develop percentages of the 1.8 million that would allocate the funding across the approved purposes. That's a little chunkily said, but I hope that made sense. So basically, we took that question, which again was, given the current reality of the opioid crisis, how would you prioritize the approved purposes? And on the left-hand side of the slide, you see the answers to that. The majority of the group believed that the highest priority was treatment, and then harm reduction, and then recovery, and then criminal justice, and then prevention and education. We did some fancy behind the scenes math, and basically that comes of the $1.8 million. That means treatment would get 29.7% of the funds, harm reduction would get 18.79% of the funds, recovery gets 18.18% of the funds, criminal justice 16.97%, and prevention and education gets 16.36% of the funds. So at this point, we were still looking at 34 projects and an overage of 1.4 million. So then we created work groups that were specific to the approved purposes. And those were personed by individuals with subject matter expertise and working in that area, from representatives from the operations group. So they were able to actually look at all the projects that were recommended and scored high and figure out, really, given what they know from working in the field, what were the current priorities and necessities. So we, at that point, based on the work of 4 work groups, they were narrowed it down to 25 projects, and we came in under the 1.8 million by $162,393. And the reason we did not have 5 work groups is because there weren't enough recovery projects to use the full allocation that was given for the recovery approved purpose. So they didn't need to have a group to muck through how to shrink it down. Are there any questions about the process?
Lisa, it's Susan. Sounds like an awesome process. I just had a question though, between slide 31 and 34. I might be missing something, but on slide 31, I wasn't seeing anything around harm reduction in the where is the biggest need. So I was just confused on how that ended up being ranked second on slide 34. I probably missed a step there.
So on 31, it was the question of where was the biggest need, and harm reduction actually did not come up at all on that ranking, on that score. It got to 0. And I think it's because where things are currently, harm reduction is one of the bigger strengths in the county. So in that, the biggest need is, like, think of it as the biggest gaps.
Okay.
So then when we move forward to this one, the reason it came up second is it's a different question. This question was, given what's going on right now with the opioid crisis, how would you prioritize funding?
Okay. Thank you for that.
I have a question as well, and maybe you could leave that slide up. I think it's number 29. Yeah, or I guess I have a different set of, no, yeah, you were on the right one. Go back.
Okay.
Yeah, that one. The delineation between treatment and recovery, sort of a continuum, and it seems, the way I understand it, maybe recovery supports relapse prevention and maintaining whatever progress is made in treatment. And I think I heard you say that we didn't have enough recovery people from the recovery community or recovery programs to put a working group together to identify investments for that. But I wonder whether that isn't indicative of the need to actually dedicate more funding in that area, because again, just from my lay perspective and everything I've read about this problem, it seems like a really important part of sustaining treatment.
Yeah, I think you're absolutely right. The mitigating factor here was that we were moving with a shovel-ready project, and which is, it has its shortcomings in the sense that there isn't anything at this moment that was shovel ready to move forward in the recovery space. I mean, beyond the 3 projects that we got. Yes, it means that we have a huge gaping hole in the space of recovery in the county. What we did do is we collected every project that was not yet shovel ready and have a huge list of aspirational projects. So essentially the group's recommendation probably, down the line is as we begin to engage in the question of really what should the full continuum of opioid related services be in the county, there'll be a huge need to invest in recovery.
Okay, yeah. So, I mean, in a way that speaks to one of the shortfalls of focusing on shovel ready, although I understand this is just the first year's funding, and we do want to get these funds out and put them to use. So I guess with the understanding that that's something we'll try to address as we move forward. I think this is a great process.
I have a quick question on that. So when we look at the funding and we look out over time, what's the growth in I mean, this is kind of getting to what Claire's talking about. What's the growth of the funding over time? And how are we looking at what we're funding now in terms of, are we treating it as one-time dollars, or are we using what I call one-time to fund ongoing expenses? And so it really is, the question is, what's the growth in the funding pie? And are we committing funds today that will limit some of these things that we're talking about in the future?
I don't even know how to answer that question. I'd like to hand that off to Jim. I mean, what I can tell you is what we were looking at was a 1-year plan. And as Kelly mentioned, there's more money in year 1 and then around $1 million for each year afterwards. It was part of the complication of all of this, is $1 million in the scheme of the need is not a huge amount of money.
I guess the example I will give you is, so when we look at it, we ask questions in our budget process. Is this an ongoing expense or is this a one-time expense? And if it's an ongoing expense, meaning we're going to have to fill that gap in the future, being cognizant of that, because that may limit your funding options in the future if they're going to continue to need this funding to keep the program going.
So, this is a 1-year infusion of funding for the projects on the list. Many of them will have ongoing costs for which it is not a given that this funding is available for.
Okay.
And
I will
Harold,
just,
oh, I would just say that what
Yeah.
we know is that our time frame is these 18 years of with about $17 million plus additional dollars that will come online as there are new settlements. And so this first year was really opportunistic in that we took advantage of projects that were generally ready to go. What the plan is moving forward is to be much more strategic in thinking about investments. And so as we move out of this first year, how do we engage in processes that better look at the system's needs and how we invest dollars into building a system around opioid use disorder that's much more strategic, targeted, and longer term look at how dollars are used.
I think it was Susan first and then Nuria.
Yeah, we've talked about this before, and it's definitely easier said than done, but I think, it's worth continuing to talk about some broader fiscal models of reinvestment. So not only looking at this pool of dollars, but what kind of impact will these dollars have on intervention systems where we could potentially look at better outcomes, shorter lengths of stay, things like that, where there might be dollars that from those systems that could be freed up and start to invest into prevention and early intervention. Again, it's complicated, and I don't know how much data we're going to have on all of these programs or the impact on the broader systems, but I think it's worth talking about if there's opportunity there, because not only are we looking year to year, year over year with these $1 million that we have for this, we're starting to look at broader impacts and potential again for reinvestment for that.
Thank you, Susan. Nuria?
Yeah, and I appreciate the conversation thus far. I now have two comments, I suppose. One was, I'm assuming, and maybe it's later on in the presentation, that as we're talking about these interventions, which I'm, excited to hear more about and comfortable with the approach that the recommendations, but how are we measuring that, right? So that we make sure, and some are easier to measure in a 1-year term and others just require more time, that as we're investing time after time, that we're actually investing in the right thing, right? And I'm sure everybody's got that in their minds, but at some point would welcome that conversation about evaluation as we get into this. And then the other thought I had listening to the conversation was, the cities, right, and other systems, we're investing monies in not just, right now we're talking about this money that is coming from a very specific source, but in addition to that, cities are investing monies in similar or complementary programs, and whether or not this work also can leverage the work we're doing, and or whether our work could leverage this work, and how do we bring those more cohesively together, and then hopefully expand and maximize the impact that we're having with the dollars that we're either using from this fund, but in addition to the funds that we're all putting into this as municipalities or organizations in general. And so that to me is a thought of aligning our own programs as at the same time as this work is moving forward.
Thank you. Carol?
Yeah, and actually to give some context to my question, so I saw Rewind, I think, is one of the programs that was listed. And I saw our lead core program. And the reason why I asked the question is this a one-time money coming in from you all, and then in the next budget process, they're going to want me to fill it with internal funds if they don't get it? So that was really the genesis of my question. And I wanted to say, I do agree with Nuria, and I put in the chat is, how are we building in program evaluation into this and utilizing potentially outside program evaluation groups to come in, and what is success? are we achieving it? If we're not, why? And are we building something in to pivot because we want to invest in things that make a difference?
Thank you. Daria, did you have another question? Okay.
So Lisa, I just want to be thoughtful, and it's not just to you, but for everyone, is that we're running out of time, which we knew we might. And so just to be thoughtful about that.
Well, I'm actually ready to hand off to Marcy.
Hi, everybody. I'm Marcy Campbell. I use she, her pronouns. I'm the Behavioral Health System Project Manager and have been working to support this project. So my charge for today is to give you an overview of the thoughtful programs that the Opioid Operations Group is recommending. And just to let you know, this is today just a high-level overview and an introduction. There won't be a decision point today for these particular projects. You'll have some materials that you can be taking a look at after this meeting and before the next meeting to give you a little bit more time to process the details about the different programs that we'll be talking about specifically today. So I just wanted to highlight that before we dive in specifically on those particular projects. So you are used to this pie now. This shows the different funding that is broken down across the 5 approved purposes. So it just highlights again, as was mentioned, we were working off of that 1.8, and this represents about $1.6 million that the operations group recommended for specific projects. And there is that unallocated portion of funding, which I will talk about before we take our next pause. So first, we'll take a look at harm reduction. And so that is just a piece of the pie, and you can see that it's broken down into 5 different programs that total $310,000. And that represents 18.79% of the funding. And so I'll talk a little bit about the different programs, but I want to orient you to these tables that you'll see for each of the approved purposes. So for each, you can see that there is a list of a program name that is highlighted, as well as a particular organization or jurisdiction related to the program and the funding amount. And those are oriented from the most expensive to the least on the list. And so just to tell you a little bit about the programs here for harm reduction, you'll see that many of the programs are based out of Boulder County Public Health. And as has been mentioned, the WORKS program is our key provider of harm reduction services, such as syringe exchange. And there's also a project for the City of Longmont's parenting support, specifically for those harm reduction programs. So taking a look at, for example, the overdose prevention vending machines that are on the list, there are some projects that were specifically more like a one-time funding, speaking to your previous point, and those particular vending machines are one example. One is to be located in Nederland and one in Lafayette to really expand the reach of syringe exchange opportunities. So those programs are taking into consideration the regions and those types of things as well as we take a look. Next on our list is prevention and education programs. So you can see we have a total of 7 programs that represent almost $300,000, and that full percentage for prevention and education is 16.36%. So there's a variety of programs that are available that were recommended by the group. And I'm seeing a note about this that I'll go ahead and get to as well, just that these aren't replacing existing funds, so it would be an enhancement of funding. And so in the list of prevention and education programs, you can see a wide variety of opportunities here, including a community Narcan web, which provides training for Narcan expansion. So it's training to help folks understand how to use Narcan and actually distribute Narcan. Includes a train the trainer model and really is geared towards spreading that reach all across the region and to different priority populations. You can also see opportunities to reach priority populations through community health workers, through school education in the youth and recovery program, for example, and a variety of other opportunities such as our SWAG group that has been doing amazing work for a long time in the community. Our next set of programs is in the criminal justice realm. So that's the approved purpose that represents about 16.97% of the funds. And those 5 projects here that you can see on the screen. One is to support medical assisted treatment in the jail, as well as there's also a case management program specifically for opioids through the sheriff's office. Additionally, as you saw Emily share about the data on the substances coming into the community, there is also investigation equipment to track that particular purpose. Next on the list, we have treatment with 5 programs. So you can see a variety of opportunities with treatment. That was our largest approved purpose. So folks put 29.7% as that amount for these particular programs. And you can see a list here. I know Rewind was referenced as one of the programs that offers bilingual bicultural services. And LEAF is providing some mountain services. So again, you can see how equity and regional reach was considered throughout. Last but not least is recovery. There were 3 total programs that were recommended for the amount of $200,000, which again is less than the 18.18% that the group put aside. So there is some recovery programs for LGBTQ plus individuals, some work in the city, as well as some outdoor recreation and recovery support specifically for individuals. One thing that we mentioned was that there were unallocated funds, and the Opioid Operations Group did take some time to provide some recommendations to this group on how those unallocated funds might be spent. And you can see a variety of things, including pieces that y'all have talked about today, but we also talked about that reserving some for administrative costs, which could include the evaluation piece that you all have discussed as well today. So I'm going to pause briefly to see if you have any questions, but want to make sure that you are aware you don't need to decide on these today, and Tucker will walk you through how to look at all of the great materials that we put together to make sure you can see the real details about these specific programs. Susan.
Thanks. Looks like an awesome list. So I'll wait for some of my questions until I look through more of the detail that Tucker will provide. I did have one thought about the unallocated funds and just wondering if it's been discussed around flex funds that go directly to individuals or families who are in recovery. Is that part of any of those programs? And does it even meet the criteria to do direct cash assistance for basic needs support, those kind of things for families? Or just curious.
Yeah, off the top of my head, I'm not sure about that in terms of the approved purpose, but I think that's definitely worth something that we can dig into when we talk to the operations group next time.
Thank you.
Yes. Commissioner Levy?
Yeah, thanks. And this is a fantastic start. And I know what I'm about to say is opposite of having shovel-ready projects, but just on the treatment investments in Lyons was mentioned as helping serve the mountain communities. I guess I wouldn't, it is a small rural community, but I think we really need to work hard to find some services up in Nederland. A very distinct community, has its own challenges. It's got transportation challenges. in addition to just its location. So
Definitely.
there may not be anything here now, but I hope we can find something.
Yeah, thank you for raising that. We did some specific outreach to the mountain communities to try to find opportunities to add things to the shovel-ready list. And I think, just as you said, that there may be some things that are in that aspirational space or opportunity for us to think about in the future. Nuria.
Yeah, just a quick question. I was wondering, in these list of alternatives or suggestions that sound really terrific and well thought out, where would peer support land in some of these buckets? And were some consideration to that, knowing how critical that is to success?
Absolutely. Yes, peers were definitely recommended and were part of several of the offerings that came forth, including the, let's see, I don't know if I can dig into all of them fast enough, but I know the LEAP program includes some peers. There are peers in the Mental Health Partners Community Health Worker project as well. So that there's several throughout. That was something that really came up as a strong desire of the operations or the opioid operations group. And so you'll be able to see those nuggets as you tease into the details of each projects. But I think that's something that the group wants to keep on the forefront for the future dialogue, as well as is how do we continue to support peers in this work.
Agreed. Thanks so much.
Absolutely. I will pause, and now I'll go ahead and turn it over to Tucker, who's going to dig into how to look into all of these great materials.
Awesome. Thank you, Marcy. Hi, everybody. My name is Tucker Uhrman. I am a member of the Behavioral Health Planning team within Boulder County's Community Services Department, and I use he, his pronouns. I'm going to take what Marcy introduced as far as the specific programs and kind of walk us through how we actually then take those and receive funding from the state so we can start distributing that throughout our community. So the Attorney General's office created what they call COST, which is the Colorado Opioid Settlement Tracker, and that's their online database for tracking the funding, actual settlement dollars themselves, as well as where we as a region will go back on an annual basis and upload expenditure reports. And it's where we'll go in and allocate funding and then make those funding requests. So like Kelly introduced at the beginning of this presentation, the Operations Board has been going off of some documentation from the Attorney General's office that lined out the purposes for the funds in 5 different approved areas. And then once the cost system was released, they changed it to align more with the state's MOU, which uses 3 what they call approved sections. So the approved sections, approved use sections are broken down into different approved use areas and then nested even further into approved use line items. So as a region, what we will do is go in to the cost system, go into the approved use sections, and actually then put funds into approved use line items. So as an example, recovery was an original just kind of approved purpose bucket. As far as the state's system is concerned, and kind of going to your comment, Commissioner Levy, the recovery is in the treatment approved use section within the people in treatment and recovery approved use area, and then recovery is its own line item. So that $200,000 would be then put into that line item. And so for the cost system, when we go to request the funds, we don't have to put program information. The actual programmatic information will be necessary next September in our annual reports. So at this point, we'll just go in and kind of allocate our overall funds into the different buckets. And then for the for ease of understanding and purposes moving forward, the operations board, and we're recommending that this council as well stick with the 5 original approved purposes, knowing that as we enter the funds into the cost system, it is broken down and the language is slightly different. But with the slate of programs that we're recommending today, that broke down into 15 different approved use areas. And so we figured the 5 sections is just easier to kind of stick with and understand. And then as far as requesting our funds, the submission dates for this year 1 funding request, the first one was September 15th. But moving forward, the state has been flexible for this first year of funding, knowing that every region is kind of figuring out their processes. So we have November 1st and December 15th. As windows to be able to then go into the cost system and allocate where we'd like the funds. And then the Attorney General there, what they are calling their Colorado Opioid Abatement Council, will then review those funding requests and then approve them. So I've gone through all of the recommendations, the programs specifically that we are putting forward today, and made sure that they have a line item in the cost system. So we're anticipating that everything put in front of you would be approved by the Attorney General's office. And then on an annual basis moving forward, it will only be open on that September 15th window to be able to go in and submit our annual submissions. And then every spring in March, on March 15th, we can go back into the cost system, move money between different buckets, and request additional funds should we have funds left over. So kind of like we're figuring out here, the operations board was going off of that $1.8 million number. Recently finding out we have $2.26 million, which is awesome for our year 1 funding allocation. We don't have to use all of that money. It will kind of be stored, and so we can go back at a later date and pull additional funds if there are additional funds left. And then lastly, just to kind of wrap this up, Robin sent out last week a packet of information about all of the programs. So I'll just kind of run you through that. And then Robin will kind of work you through that at the very, very end. But the packet of information is broken into 2 sections. The first section, kind of as Marcy was going through, is a high-level overview of all of the programs. It's laid out a little bit differently. So rather than using the 5 approved purposes, the programs in this first section are laid out as how they would line up in the cost system. So you can see how they'll fit into the state's system. So that's just high-level information, and then actual program details are then in the second section. So that includes some information about, like you were asking about, Commissioner Levy, of is this sustaining a program that's losing funding or expanding an existing program? Does this what kind of service is happening at this point, the geographic representation, stuff like that. So we have a lot more information about each individual program. So if you have questions about a specific program, please reach out to Robin, and then she can kind of direct connect with the appropriate person to answer that question. And with that being said, then I'm going to just turn it over to Robin, who's going to kind of explain where we're going from here and wrap the meeting up.
Thanks, Tucker. And I just really wanted to thank our staff team for this amazing download of information. This has been complicated work and continued conversation with the state, as what happened today when we learned we had additional funds. So thanks to our staff team and to the operations board for doing the heavy lift. So again, we would really like to submit our plan for the November 1st deadline, which will require us to determine those allocation cost buckets of dollars, not the specific projects. However, we really want to hear from you if you have any concerns about the projects. We'd like you to review them. Many of your staff have been involved in putting them forward, so you may already have a lot of knowledge about them. We also want to especially hear if there's critical projects missing. You know, so Claire talked about treatment as well as recovery was mentioned. And so if there's something that you really think we should propose in this first tranche, remember, we have opportunities in the future. And then we'd also like your eyeball on, you know, that pie chart that showed the general allocation of dollars by approved areas. So if you think we should put more in the treatment pie, we want to hear about that. And then, you know, again, our IGA talks about that we're making decisions by consensus. And so we'd like to hear from you if you have concerns. What would you need to hear from us, or what would you need changed in order to move those projects forward? And then again, today we were thrown a curveball. We heard that we had almost $500,000 in additional funds. We'd like to recommend that we actually start with the existing project proposals and the amounts, and then look at what do those additional dollars allow us to bring forward in for year 2. So that would bring an additional $1.4 million. And then we can play with that challenging conversation about what's sustainable funding versus where do we keep space and funding for new programs, as maybe existing programs actually impact the community in a positive way. So that's your homework assignment. And I'll pause there in case there's any questions, because it's a little challenging. Good, we did our job. There's no questions. I'm sure you have lots of thoughts and lots of questions. This is lots to digest. Because we're out of time, and I think what we'll do is we'll figure out the scheduling challenge for an October meeting offline in a similar way that we did. We'll probably use a doodle poll again. And you know, any lingering questions that you have, again, it's a lot to digest and process. I think just for ease, if you want to send those to me, and then I can point them to the right people to get the right answer, and we'll make sure everybody gets the question and the answers. And then I'll stop as we're 4 minutes over, but I just wanted to offer any comments from anyone for the good of the order, as well as turn the conversation back to Claire if you have any closing comments. And again, so appreciate your engagement. It's very, very helpful.
I'm going to pause and see if there are any other comments for the good of the order. No, because it's 5:05. And so, no, I'm just going to thank everybody for what you're doing to help us spend this money. It's your money too, really wisely. We've done a tremendous amount of work behind the scenes to get us here. And I think we're off to a great start. I just want to appreciate all that work, and look for the doodle poll. Let's get that filled out as quickly as possible. And we know what a challenge it is to get this high performing group together. So thank you. I guess that is the concluding remarks. So we'll go ahead and end the meeting. Thank you. Thanks. Bye-bye.
Thanks, everyone.
Thanks, everyone.